Okay, so we can just get started. Good morning, everyone. My name is Lauren. I'm one of the hosts for Grand Rounds with Global Offsite Care. Today, we have a presentation with Dr. Gill and his medical student, Stephen. It's going to be on hyponatremia. And just to kind of give some more information to our viewers, we are doing asynchronous now, CME, if that's something that you guys want to be doing. We usually post the videos now within a few days, and then I believe it's up to a week where you can submit for CME. The link is also on the invitation that you guys receive. But other than that, uh, we're ready to go. And I'm going to hand it over to Dr. Pecchia, who's going to give a little bit more introduction to Stephen and Dr. Gill.
Great. Lauren, thanks so much. I appreciate it. And thank you always for your hard work and your years of service to Global Offsite Care, organizing and moderating and getting the ball rolling on these meetings. So with that, a little bit about myself. I'm the current medical director of Global Offsite Care and the moderator for most of these Grand Round sessions. I'm a associate professor at Western University of Health Sciences in Pomona, California. We also have a campus in Oregon, Central Oregon, as well as the director of telemedicine and the telemedicine curriculum there. Trained in geriatrics and primary care. With that, I'd like to introduce Dr. Gill, who is an internist and tele-intensivist, part of the movement to make medicine better in any way that telemedicine platforms and workflows can benefit people in need internationally as well as locally. So thank you, Dr. Gill, for that. He's also an assistant professor of internal medicine at Western U. We also have today a fourth-year medical student, Stephen Soltani, currently on a rotation in telemedicine at Western University, and comes to the university with a passion for anesthesiology and primary care. He's currently in the cycle of applying to residencies for those specialties, and tells us that his passion is really to deliver his medical knowledge and training and experience to return to his community and provide medical care to his community. So thank you, Mr. Soltani, for joining us. And with that, I'll give it up to Dr. Gill.
Good morning. Thank you. Thank you for your gracious and kind introduction, Dr. Pasha. All right, good morning, everyone. Let's review today's topic, hyponatremia. And I like to call it salt and water homeostasis. And our bodies constitutes majority part of our body is actually water, and the water is life, as so say. So with that, let's get started. Go to our first slide. I'd like to define hyponatremia. It's actually excess free water relative to salt. Content of salt is controlled by amount of water. Basically, the controlling factor is the amount of water in our body, which is followed by the amount of salt that body retains. And therefore, in order to have the normal sodium level, the body has to balance out the amount of water, not the other way around. It's kind of the concept of salt and water homeostasis. Therefore, the total sodium level in our body is dependent on total fluid volume, intravascular and extravascular, and the kidney filtration rate, function of kidneys, and vasopressin ADHD. They are major regulatory factors, as well as the renin-angiotensin aldosterone mechanism, which is independent of ADH. Alongside of hyponatremia, it is important to understand the level of potassium ups and downs and cortisol and thyroid and urea excretion in order to have a full grasp of hyponatremia. Because ADH, apologize, the vasopressin is affected by cortisol and thyroid level. The mechanism is not 100% understood, but it's not dependent on cortisol, thyroid, but the level of cortisol or thyroid does affect the vasopressin function. And the last point before we actually get to our discussion about hyponatremia, don't be afraid of little math. Let's go next slide, please. Okay, so the balance of water and salt, try to make it simple. The ingestion of salt and water, and there are three major losses: urinary, fecal, and skin and respiratory. The intravascular fluid volume gets balanced by extravascular fluid volume, and if no other comorbidities, no other medical illnesses, it keeps its balance back and forth via capillaries, intravascular, extravascular. And then comes into play the hormonal system and nervous system, and the vasopressin, renin-angiotensin aldosterone. All these systems of body, they keep the homeostasis of fluid volume, and in turn leads to salt control of amount of salt in the body. The normal level of salt is, or the sodium is 135 to 145 milliequivalent, and therefore that's what we call the required oncotic pressure that it creates in the body, and anything above and below that creates pathological phenomena. Next slide, please. So roughly, on average, the turnover is about 300 milliosmol of sodium, which is about twice 150 milliequivalent. And just to have a little more in-depth perspective, the normal saline bag that we give to patient, which is the most common form of fluid resuscitation, has 150 milliequivalents of sodium chloride in it. So as you can guess, about our daily intake in amount of salt is about 2.5 grams to 3.5 grams. However, you convert into a rough turnover, it's about 300 milliosmol of sodium over 24 hours. And in conjunction to that, about 2 liters of water. So if someone to drink 2 liters of water, 2 liters of fluid, the total amount, kidneys can function well and balance it out without affecting the normal oncotic pressure of or the tonicity of intravascular fluid. More than 2 liters, kidney get under pressure and it might not be able to excrete extra water, which in turn leads to hyponatremia and drop in sodium. So serum sodium 135 to 145 is actually what the body keeps it for normal functionality, and below and above is called hypo and hypernatremia. The cardiac output is necessary to keep normal homeostasis of intracellular, extracellular, extravascular, intravascular balance. Um, the hyponatremia affects the um, brain cell in a little slightly different way than rest of the body, because brain cells have this blood-brain barrier with the rest of the body. So brain cell adapt to sodium level, but takes about 48 hours. The urine sodium usually have an inverse relationship to urine osmolality, have inverse relationship to serum osmolality. Um, Understanding, again, I will repeat, is vasopressin or ADH. There are three ways that ADH is released: the osmotic and physiological and pathological stimulus that creates increase the level of vasopressin. The osmotic way is when someone takes a bag of potato chips and it rises, increases the blood osmolality, and it senses by the pituitary senses high osmotic stimulus, and in turn then releases a vasopressin, and receptors are on kidney tubules, which in turn save more free water and try to balance out the oncotic pressure. Physiological is CHF, hypovolemia. Again, pituitary, anytime it senses either there is an osmotic change or there is a volume change, it responds by increasing ADH levels. Therefore, renin, angiotensin, aldosterone, in turn, eventually leads to level of sodium and free water retention by mechanism of affecting the volume. Pathological is ectopic is and the medications, certain medications that increase pathologically, MDMA, like ecstasy, patients coming from rave parties, they have this SIADH and pathological increase of antidiuretic hormone and leading to severe hyponatremia. Next slide, please. Okay, so I was just mentioning, take extra bag of potato chips in the diet, rises sodium osmolality, thirst, ADH release, and enhanced renal tubular concentration, high extracellular volume. If healthy individual, the GFR goes up and therefore diuresis happens. So normalization of serum osmolality. Corrupted water balance, which is CHF, cirrhosis, renal failure. That body loses ability to have normal diuresis, and so the contribution happens by vasopressin, so more free water retention, and that leads to hypervolemia. Next. Let's go to etiology. And we have various pathological phenomenon leads to hyponatremia. Hyponatremia is a result of many comorbidities, and by itself it's a disease as well. So in order to simplify the etiology, first we take the osmolality and see if it's a hyponatremia with actually starting with the level, the amount of sodium in our body. So anywhere, if we have less than 280 milliosmol, it falls in definition of hyponatremia, true hypotonic hyponatremia. And more than 295, as hypertonic, and osmolality is normal as isotonic. Now, we still call it hyponatremia because the relative or the required amount of sodium is still less. However, the tonicity is high or low. And the examples are hyperproteinemia, hyperlipidemia, hyperglycemia. You see, the if high protein, the body will still have the high tonicity, normal tonicity of the fluid, but the sodium level will be low, and so that's could be a deceiving. Hypertonic hyponatremia, for example, hyperglycemia, infusion of mannitol, sorbitol, um, any solute that increases the tonicity is classified as hypertonic hyponatremia. We also have the diagnosis or a term pseudo-hyponatremia, for example, in case of DKA, diabetic ketoacidosis, and high glucose level. Roughly every 100 gram of 100 milligram of per DL glucose rise above normal level drops or needs correction of sodium by about 2.5 milliequivalent. So that's sort of a rough formula to correct the sodium. So if sodium level, say, is 130 and glucose is 200 or 300 milligram above normal, we have to add 5 milliequivalent for 200, and similarly 7.5 milliequivalent for 300 milligram of glucose above normal level, respectively. Next slide, please. Let's discuss hypotonic hyponatremia, which is our most of our discussion today. We divide between three, again, major categories: hypovolemic, euvolemic, and hypervolemic. Hypovolemic, relatively easy to understand. If kidney functions is normal, able to hold on to sodium, the causes of dehydration, diarrhea, vomiting, and defection, excretion of sodium is less than is normal. So the urine sodium will be less than 10 milliequivalent, which reflects normal kidney function. Is just to respond to volume loss or decrease intake. Renal salt loss could happen either by insult to kidney tubules or use of diuretic or forced diuresis, and that could cause hyponatremia, one of the common cause in our patients. Euvolemic gets a little complicated here, and the causes are SIAGH, post-operative, hyponatremia, hypothyroidism, psychogenic, hyponatremia, and there are, again, thiazide and ACE inhibitors have some other effects on release of vasopressin, injurious exercises, and adrenocorticotropic deficiency. Hypervolemic is actually the congestive heart failure, liver disease, nephrotic syndrome, and renal failure, anything that affects the excretion of salt and water and have wrong signals to retain more salt and water. Next slide, please. It's major cause mortality. I have the study with the reference that in Ohio, there were about 53,000 patients studied in a major hospital system. And what they studied was the association of major illnesses with hyponatremia, the significant rise in mortality that they found. 37.9% of patients had less than 138 milliequivalent per liter sodium level, the inclusion criteria, and the relative mortality relative to other patients was higher, about 1.552%. LOS was 14%, and discharge to short to long-term care was also increased. Next slide, please. Serum osmolality and neurons. Now, in case of normal sodium level, the brain cell have its own osmolytes, sodium, potassium, organic osmolytes, and chloride, slightly different than bloodstream. Now, when hyponatremia happens, the brain cells are separated. There's no direct contact with extracellular fluid or intravascular fluid. So the water by osmotic pressure moves into brain cells, and which leads to swelling of brain cells. If it gives time, if it happens over a day or two or few hours, brain cell will sense that and start to push out its organic solutes and inorganic solutes in order to compensate for the swelling. So brain cells adapt to this osmotic abnormality pushed from the extracellular, outside blood-brain barrier. However, if it happens so quickly, then brain cells start to swell, and that's how we get symptoms of acute hyponatremia. And with this concept, when we are correcting if you see the fourth picture in the picture of osmotic demyelination, the D, what happens is the brain cell has already pushed out its solutes, the organic and inorganic, and has balanced out the osmotic pressure. Now, if we to correct sodium quickly, don't give time for brain cell to take back its solutes, and what happens is that the free water from brain cell rushes out from brain cell into the vascular space because of osmotic pressure. Because we put, for example, 3% sodium. If we infuse 3% sodium at a higher rate than recommended, then the brain cell will shrink, and in turn that leads to demyelination, shrinking, and pontine herniation. The brain cell that adapt is a rate of adaptation is about 0.5 milliequivalent per liter. So you have to give the rate of correction should be about 0.5 milliequivalent sodium per hour. That gives enough time for a brain cell to adapt and keep its normal osmotic pressure without either swelling or shrinking. Next slide. So let's review our first case. This is actually a true case that I took care of. 78-year-old female brought to the emergency room by her daughter. She was progressively getting confused over 2 weeks period. She had fell. Now that after she had 2 falls, daughter got worried that it's not just her dementia, but there's something going on. When patient was admitted, kind of a little typical in a very fast-paced hospital environment, and the hospitalist who admitted the patient was not able to get detailed history, so review system unable to obtain kind of situation. Patient past medical history of dementia, depression, hypertension, hypothyroidism, home medication for Aricept, Synthroid, hydrochlorothiazide, Norvasc, and Lasix here and there. On exam, patient was afebrile, vitals were normal, exam was essentially normal. Higher mental function showed executive and function and memory was affected, and no specific neurological deficit. Sodium was 128, serum osmo was 275. Next slide, please. So what would be the differential diagnosis of this patient? Could it be psychogenic polydipsia? Psychogenic polydipsia is when we have a normal body have a normal salt and water excretion. The kidney is able to maintain or retain the ability to normalize osmotic pressure of extracellular fluid. However, psychologically, out of obsessive compulsive disorder or depression or anxiety, somebody drinks more than 2 liters per day. So that leads to a hyponatremia because kidneys just not able to keep up with so much free water intake. Diuretic-induced hyponatremia, that's forced diuresis, where the kidneys are not able to retain sodium, or we don't want it to retain sodium. And that's sort of a side effect or a overly corrected actual cellular volume expansion in case of CHF, cirrhosis, and renal failure. Hypothyroidism is actually vasopressin related, and I think that the mechanism is not well known. Tea and toast diet. Well, in this situation, it's like hyponatremia, which is a beer drinking and alcoholic patients, tea and toast diet. These are those situations when patient is not taking enough solutes, or organic and inorganic both, not eating enough. However, drinking normal amount of water. So that leads to this intake hyponatremia. So could it be all of the above? So our differential actually led to all of the above in this case for that patient. After we talked to the daughter, it turns out that she's just a tea and toast diet patient, drinking so much water because she's anxious. She was having a caregiver. She was living alone, and she's hypothyroid. So, body does not come out as a textbook. And it was a very interesting case with that. So next slide, please. So when you approach the hyponatremia, the most important part of approach, the diagnosis, differential management is history. Really a good, detailed history from patient. If patient is not able to talk, they have symptoms of hyponatremia, and usually they do when they present to the hospital. And if they don't have that severe symptoms, ask patient, ask amount of water they are drinking, family or caregiver. See how much is their solute or food intake, the amount of salt intake. And just by detailed history, if we follow the pattern, the medications, the review of systems, does patient have any recent surgery? Does patient have any head injury? If we take detailed history and look at the labs, by the time we have gotten to our laboratory data, the picture is kind of pretty much clear what's going on. Next slide, please. Signs and symptoms depends if it's acute or chronic over time. Acute hyponatremia occurs due to osmotic swelling of brain, and it's so severe that brain is not able to adapt, and therefore leads to nausea, vomiting, headache, confusion, eventually seizures, loss of consciousness, pretty severe. And if it's asymptomatic or slow symptoms, if it's chronic, hyponatremia has probably occurred, most likely over days and weeks, which leads to loss of executive function, falls, sudden change in memory, and family usually say, I don't know, but my mom or dad is just not the same suddenly, and could be asymptomatic. Next slide, please. Medications cause hyponatremia, MDMA, SIADH, turn, then thiazide, narcotics, nicotine can cause that, SSRI, antipsychotics, tricyclic antidepressants. If you see any of those agents in a home medication list, please inquire the dose, intake, and how long they've been taking. That could very well be a contribution into hyponatremia. Next slide, please. General principles, we have to determine the severity, the duration of symptoms, and what kind of symptoms. So, for example, in case of DKA, that's kind of truly pseudo hyponatremia. So probably we don't have to do much here. Correct the sodium level in relative to glucose level, and correct DKA and sodium level in the lab will come up. This is a lab hyponatremia, not true hyponatremia. Always have to remember to check potassium with it, and urea as well if we are suspecting, especially SIADH. Hypertonic solution only in case of severe and symptomatic hyponatremia. As we discussed, brain take about 48 hours, and so the rate of correction should be 0.5 milliequivalent per liter per hour, except if there is acute hyponatremia. We'll discuss that later. Next, please. So all the patients that are walking to clinic with mild symptoms, take good history, list out multiple causes, which usually are, calculate accurate water intake, and the lab that we will require is not a whole lot of labs actually. If we get sodium, serum sodium, osmo, urine sodium osmo, and if we know about TSH level, if patients hypothyroid or not, really takes out most of the causes of hyponatremia. Therefore, in the clinic, in the remote, just by doing a good history, medications, and the pattern of symptoms and progression, it's easy to determine cause of hyponatremia. So either cut back on diuresis based on the risk profiling for blood pressure, and free water restriction as a general principle, and oral salt tablets cases there's no contraindication. Next slide. Acute symptomatic hyponatremia, which occurs over 6 to 10 hours, could be surgery, rape, kids from rave party, psychogenic polydipsia, and we, as we discussed, we have to determine whether it's mild, moderate, or severe, because the treatment depends on the level of sodium. If it's 120 or less, it's severe, and we have to correct sodium faster than actually the recommended rate, which is 0.5 milliequivalent. Here we will use 3%. however mild and less symptoms, we can take the approach of, as we discussed, the free water restriction, salt tablets, and pinpointing the actual cause which leads to hyponatremia. So when we approach hyponatremia, we really have to look at all these three components: the symptom, the degree of hyponatremia, how severe it is, and how long it's been present. So all these three major components will let us decide the next best step of management. Next. So our goal of therapy is to prevent further decline. So it's, for example, drugs. The approach would be how we treat SIADH. The marathon runner, essentially have lost sodium and water over a long period of time. So normal saline will do the correction. Psychogenic polydipsia requires fluid restriction and mental health management. SIADH, iatrogenic, for example, free water washout of urinary bladder during urological surgery or major surgery leading to inappropriate ADH secretion. Simply hypovolemic is actually the easiest most without any complication, and hypothetically ADH is high. The is equal to the treatment. Basically, any situation that leads to hypovolemia or a faulty fluid, the extracellular space leads to high ADH, and when we treat the cause, any cause that leads to high ADH, it will autocorrect. On that next slide, please. We quickly go over hypervolemic hyponatremia, discuss CHF cirrhosis again, EGFRD nephrotic syndrome, delusional hyponatremia, water intoxication, psychosis again. We treated with free water restriction, salt tablets, and diuretics. Per etiology, and urea supplements along with sodium. Next slide. Hypovolemic, it's the simple most to treat. Urine sodium is normal, and urine osmo probably is normal, and could be combined with high ADH, and actually ADH is high. In that case, if we correct volume, ADH will autocorrect. Next slide. Euvolemic, SIADH, and diagnosis of exclusion. Always think of that, and that constitutes the majority of our hyponatremia. And various causes, I try to separate it specifically because SIADH is such a vast topic and could be present in any comorbidity. Low sodium osmo, high urine osmo, normal function, and if leads to high and have high ADH, ectopic ADH secretion, pathological ADH secretion. The kidneys have normal function. The vasopressin level is high despite the normal sodium level in blood. Medication like carbamazepine and MDMA malignancy, what they do is basically malfunction of ADH. Usually the urine sodium might be normal, and the osmolality and the ADH level might be normal or high. It's the receptor malfunction at the kidney level. It's a complex process where the CNS insult, HIV, SSRI, multidimensional effect to regulatory process for sodium and water retention. stress response. There's a category hereditary SIADH. Treatment is again simple. The general approach, I did the repetition, so we can actually not get confused with different causes, thinking, oh, maybe there is a different treatment. The treatment is essentially free water restriction. We can use Vaptans, which is vasopressin receptor antagonist, and urea sodium supplements that will essentially leads to more diuresis and a loss of free water. Next slide. Moderate to severe hypovolemic hyponatremia, 3% sodium chloride should use in this case when there is symptom less than 48 hours. And hyponatremia severe with symptoms, we can use 100 ml, usually recommended 3% sodium, and repeat, and about to twice. And once the sodium is above 6, usually from what the level was, we can stop using 3% sodium chloride and just monitor sodium level and various ways like water restriction, use sodium chloride infusion. So this is use of sodium chloride, 3% sodium chloride in case of inpatient management for moderate and severe euvolemic hyponatremia. Next slide. In case of outpatient setting, usually chronic and mild, and most of patients in the clinic, this is the etiology, and symptoms can range from anywhere from severe to mild, and serum sodium and osmo usually low. Urine osmo is most of the time inconclusive at that time. By the time kidneys don't have enough sodium to excrete, kidney function might be normal. We have discussed the etiology of chronic hyponatremia. So history present illness, the detail, the symptomatology, medications, all this detailed history essentially is a very good approach in those cases. It could be podomania, diuretics, polydipsia, hypothyroidism. Again, treatment, free water restriction, again, repetition. For the management, B2 receptor antagonist and urea and sodium supplements. That, we have next slide. And here I will give it to Mr. Stephen Sultani.
Thank you, Dr. Gill. All right, so this is going to be our second case for today, and this is based off a case report that we found. So involves an 83-year-old female that presented to the clinic. She had complaints of feeling tired. She was now exhibiting signs of confusion, altered mental status. Her primary or past medical history was significant for hypertension, Crohn's disease, chronic anemia, and low calorie and salt intake. She had just started taking iron sulfate for the chronic anemia, actually. And she had recently developed these bouts of reported diarrhea. And her vitals included a heart rate of 73, blood pressure 137/67. She had a normal oxygen sat, BMI of 20, and her sodium level on admission was 126 and chloride was 86. So overall, in this case, there's a few things that stand out that could be a potential cause of her hyponatremia. Number one, I think, is the diarrhea, which I actually found a little bit interesting because in most people that take iron sulfate, the most common complaint is constipation, if there is any sort of GI complaint that they have. But in this woman, I believe because the idea is that because she had Crohn's disease and her duodenum was likely had damaged mucosa, she couldn't properly absorb the iron sulfate that she began taking. And because of that, it further continued down her GI tract and led to free radical, or it leads to free radical formation further down the GI tract, which can damage the mucosal lumen and lead to diarrhea through that way. So I thought that was kind of an interesting, kind of like an atypical case of diarrhea in someone taking iron sulfate. Another reason for her hyponatremia could be also exacerbated because of her taking hydrochlorothiazide. She most likely did not stop taking the water pill, even though she had the diarrhea, so that probably contributed to the salt loss. And then finally, as well, this lady said that she was mostly drinking water to replenish the fluid that she had lost through diarrhea. And kind of like Dr. Gill was mentioning earlier with the tea and toast diet, she was likely replacing a lot of her volume with water, but not as much salt or any other osmols, which would also contribute to the hyponatremia. So next slide, please. So yeah, the approach to this case, yeah, multifactorial hypovolemic / euvolemic hyponatremia. A urine sodium check in this case would have limited value. So a conservative treatment to combat this woman's hyponatremia would be to cut back or just stop the hydrochlorothiazide for now, replace nutrition, and find the true etiology of the diarrhea. Serum sodium should be corrected slowly. So as said before, about 0.5 milliequivalents per liter per hour. And then also, yeah, screening for hypothyroidism, malignancies, or CNS insults. That could also be contributing to the hyponatremia. And specifically in a resource-limited environment, if let's say that there weren't labs to be taken, or there's not even an IV, probably at least what could be done in a resource-limited environment would be to stop the hydrochlorothiazide, maybe drink an electrolyte-rich beverage to replace the salt and water loss instead of just only water. In fact, even making like a simple ratio of about maybe 1 teaspoon of salt to about 6 teaspoons of sugar in about 1 liter of water will create a solution that contains a little bit less than 250 milliosmoles per liter, which is ideal for correcting hyponatremia in a case like this. So yeah, I think that's important to note for what could be done in a resource-limited environment. And yeah, next slide. And that concludes our presentation. So thank you for listening, and please let us know if you have any questions.
Thank you, Dr. Gill and Stephen. Great presentation and information, really helpful to those of us who see hyponatremia not infrequently, particularly those in the senior population, for sure. So open it up to any questions from the audience. We've got about 5 or 10 minutes remaining. You can just go ahead and pose your question. You can pose it into the chat, whatever works best for you. I'll start with a question. Mr. Sultani, you've mentioned if we were in a resource-limited environment without laboratory capabilities and we're having to treat this individual syndromically, essentially based on her symptoms without any lab testing, if you did have access to inexpensive finger stick level or low blood volume, whole blood volume testing, what's the smallest number of lab values that if you were making a request to have a point of care laboratory available, what 2 or 3 lab values would be most helpful for you? The reason for the question is to begin the process of understanding what the minimum requirements would be for accurately diagnosing this syndrome and allowing a more focused treatment for it. So what would those labs look like? That question goes to both the medical student and Dr. Gill.
So preliminary, I think, get obviously the sodium to check the sodium level, but also the serum osmolality to see if it's hypotonic or hypertonic or isotonic.
Mm-hmm.
Yeah, that's a good answer. May I elaborate a little bit? We want to understand when we see what triggers us to get labs. Let's get back to that. Patient has low sodium level, symptomatic. For patient is symptomatic, we want to see if it's hyponatremia. It looks like patient is not eating enough. So we want to check. Usually start with serum sodium level. And if it's low, we check urine osmo, urine sodium. Urine sodium and urine osmo, and then serum osmo gives us, these 4 labs gives us pretty good picture and differential. We confirm true hyponatremia with serum osmo, serum sodium. Then we check kidney function. If the sodium, if the urine osmo is very high, means the free water is not being excreted, means the vasopressin effect is exaggerated, and there are no clear disease pattern for kidneys, which means that it could be a case of SIADH. Which is most common cause of hyponatremia. And there's another thing I will quickly mention, what we call it, the sodium chloride, 150 milliequivalent sodium chloride challenge test. That if we give that to a patient, what will happen? So essentially we expand the volume, we're not only giving the sodium, we're giving free water. So the ADH, when body gets more solute, which is 150, the serum level is 130, so sodium level rises, and which in turn leads to more ADH secretion and volume expansion, and worsen the hyponatremia. It worsens the hyponatremia in case of SIADH, and we give the sodium chloride fusion. So I hope that answers the question. Simple way. Sorry, go ahead.
Yeah, no, that's very helpful, and I appreciate that. Any other questions, comments, concerns? We're coming up to the end of the hour here. So feel free to pose an additional question. Give you a moment, and if not, I want to again thank our speakers today for sharing this important topic, and also for all of you who attended today. Again, we'll have a recording posted and available, and with that, I'll send the closing back to Lauren. And again, thank you all for attending today.
Thank you very much.
Sorry, my internet's a little shaky. I can't get my camera back on, but I also wanted to thank everyone, and the video will be available in probably the next day or so.
Wonderful. Thank you, everyone. Thank you, Steve.
Thank you, everyone. Thank you, Dr. Gill.
Stay well. Bye-bye.
Thank you. Thank you, everybody.